Really pleased to be speaking today about, it has been a journey that we've gone on in developing this concept of the living lab at home, which is a project that had first started when I was a postdoc, working under Tim's supervision, and has continued to evolve into a really fulfilling collaboration and some of the most meaningful work that I've had the chance to be involved in. I'll start with just acknowledging that those of us that are here in person today are joining on the unceded and stolen ancestral lands of the Coast Salish people, the Squamish, Tsleil-Waututh, and Musqueam nations. And, at its core, the Living Lab at Home is about addressing issues related to health equity and about thinking differently about how we do research. And this is a very fraught time to be doing research where we're being asked to grapple with questions around how research has historically done harm to many of the populations that we are here hoping to benefit. And there are harms that continue to happen in the context of health research, specifically for many of the families who are traditionally not well represented in research, often for very good reasons. So I think I have been finding continued hope and inspiration from the Coast Salish teachings gifted to PHSA, from consultation with Indigenous colleagues, and from looking to Indigenous ways of knowing to think about better ways of approaching research and about trying to live in line with our values of really putting the relationships with patients and families first. Just an overview of where we're going today. We're going to be switching back and forth in telling the story of how the Living Lab came to be. But first, we'll talk about how there are some real gaps in equity and pain research, and working in the context of developmental pediatrics. This is particularly apparent. Talking about how the Living Lab at Home approach was developed to try and improve accessibility for research opportunities for children and families. And then we'll talk a bit about sort of where we're going, where we see this work going. And this is hopefully where I might encourage you all to think about how this might be relevant to the work that you're doing, the populations that you serve, because ultimately this Living Lab concept is meant to be one that fosters collaboration, and that we're really excited about partnering with other groups around learning together and using these methods to improve issues of equity in health research. It's National Pain Awareness Week. So we're talking about most of our work in the context of pain, and both Timothy and I are both pain researchers and clinicians. So, pain is our bread and butter, but developmental pediatrics is also our bread and butter. So, and the two really make sense coming together because pain is a biopsychosocial developmental phenomenon. And this is particularly, this is true regardless of what stage of the lifespan you're thinking about, but particularly in the context of children and adolescents, who are the patients that we have the privilege to serve. It's really important to understand the developmental context and how that might be shifting for an individual over the course of their development, how this may look different for young people who have different neurodevelopmental conditions, and understanding how the various biopsychosocial components of the pain experience are going to fluctuate over time within and between young people. And we're going to go into a little bit more detail about some of the work that we've done around different developmental conditions and autism specifically, but we show this image just to give a sense of how there are all of these different components of pain that might be exerting different influences at different times, and that without taking into account an individual's developmental profile and what stage they're at, we're really missing part of the picture on what pain looks like. And now I'm going to turn it over to you. I'm going to stop calling you Tim. Feels cruel.
Well, thank you very much. Thank you, Sharon, for those kind words of introduction. Yeah, it's really a great story. In fact, we had this idea that we were going to have this conversation between the three of us, Sharon, Kaitlynn, and myself, about this journey we were on. But then we realized that we have these constraints like the internet and time, and we haven't figured out how to bend the time-space continuum yet. So we're going to just stick to some traditional PowerPoint slides. But for full disclosure, I'm actually in a 12-step support group for PowerPoint addicts, and I'm going to try to do this more extemporaneously than slavishly attack the slides, although I do have to stay on target. Okay, so this is Pain Awareness Week. What better way of understanding children's pain to think about it in a developmental context? In fact, I don't think that we can understand children's pain unless we think about child development. And the screen disappeared. So it becomes quite obvious that when we think about advancing frontiers for pain and pain equity, we have to think about how does developmental disabilities factor into pain, both our understanding of pain, our recognition, assessment, and ultimately management of pain. So today, for the sake of this talk, we're just going to focus on examples and work that we've done with autistic youth. Typically, I'll just say a few words about language to start with, because there are many different ways in which we can refer to an individual with autism, or we can use a identity first language like autistic youth. And there we go again. And for the sake of this talk, we will talk about autistic people, persons, individuals that is inherent to the individual's identity. There are many other ways of referring to autism, autistic individual, and some of that is driven by personal preferences. And in no way are we going to detract from that just because of the perspective that we've chosen to use here. One of the things that we know about autism and pain is that pain science, this area of literature, has historically failed to advance our understanding of pain in this setting. We know, though, that there are higher rates of chronic pain, higher occurrence of pain-inducing accidents, and also the increased incidence of very painful illnesses. And over the long run, without identifying pain in this context, it becomes very expensive, both for the healthcare system, for families, and for individuals in particular, both at a financial level, but also at a personal cost level. But we do know that there are differences in social communication and cognition, which are inherent to autism, and that they do have a direct impact on our ability to measure and ultimately treat pain. Pain measures have been validated in neurotypical youth, but they are clearly not appropriate in this context. What we do know is that there are times when an altered pain response leads to erroneous notions that pain doesn't exist, and that encourages, sadly, under-treatment of pain. The erroneous notion that pain insensitivity exists in autistic individuals is both not true, and it's very distracting. And so there's no reason to believe that an individual with autism can't have migraines or can't experience other chronic painful conditions. And in fact, that's exactly what we do in the complex pain services, is manage complex pain-related disease in the context of autism. And it is challenging, but it needs to be recognized and managed. So putting together what we know about pain and autism, differences in social communication leads to under-recognition, differences in developing and understanding relationships. So the social context that is so important in communicating pain. After all, we have to remember that pain is a self-appraisal condition. Our understanding and expression of pain is the gold standard. And we have to remember that there is no biomarker, we can't image it. And so we have to depend on the tools we have. There needs to be, one of the aspects of autism is a need for sameness. This reduces variability and is somewhat unpredictable responses to pain and painful conditions, and they can become somewhat paradoxical, both increased expression of pain, but also the shutting down of a response. So quiet could be equally important as an expression of pain in this context, which could lead to a hyperreactivity because of sensory experience that is experienced to something that's painful. But equally true, hyporeactivity can also lead to self-injurious behavior or pain-seeking behaviors, or what might appear as pain-seeking behaviors. So it's really important to understand the context of what autism and its disability brings to the pain context. You can have an expression that is recognizable as we would for neurotypical children, but at the same time, it could also be a paradoxical expression, thereby could be potentially misleading to thinking about pain. One of the other characteristics of autism that has a direct influence on our ability to both recognize and manage pain is pathologic demand avoidance. This is a behavior where child ignores things that are perceived to be a demand. So if you're asking a child to participate, and Kaitlynn can talk about this as well, about in a psychological treatment, this could become very difficult to move from the stickiness of PDA. It delays tactics that include distraction and may appear as shouting, following, saying that body parts don't work, negotiating, and even difficult or dangerous behaviors may appear as an expression of PDA. And in that sense, it makes management of chronic pain challenging. And so working with behavioral interventions can be very helpful to move beyond the constructs of PDA. Okay, so that's just a brief overview of autism and how it might impact our ability to understand pain. But one of the critical parts of this understanding is not only what we know, but most importantly, what we don't know. Kaitlynn, what do we don't know?
Almost everything. So I was speaking at a session on neurodiversity and pain earlier this week that was intended for patients and families. And I said during that, and I mean this quite sincerely, that I hope by the end of my career, I can say that I'm practicing evidence-based care when it comes to treating pain in autistic young people. But at this point, we just don't have the evidence to even say if that's what we're doing or not. And I'm just going to briefly go over the results of two systematic reviews that Tim and I have been involved in. This first one was looking at assessment of pain and related functioning in youth with brain-based developmental disabilities. So this was not specific to autism, but included a wide range of developmental conditions. And what you'll see there is these are the number of papers that were found that looked at some aspect of assessment of pain in the context of developmental disabilities. And the bars in blue is looking at all papers, and then the ones that are represented in orange are studies where there actually was a specific quantitative focus on pain. So it wasn't just that pain happened to be measured and the assessment was talked about in some regard, it was a specific focus on pain. So you'll see that those numbers are very small, especially when we consider how much pediatric pain literature has grown in the last couple of decades. And Canada is a world leader in pediatric pain research. And we see a disproportionate underrepresentation of young people with developmental disabilities in that literature. So you see in the context of cerebral palsy, we're seeing more papers that are measuring pain as a variable, but not actually that many papers that are looking specifically at whether pain is being measured properly or if the context is specifically focused on pain. Most of the assessment measures that are available focus on observer-reported pain intensity and severity, so very little work that's looked at actually obtaining a self-report from the young person themselves. Often pain intensity or severity is the only variable that's being looked at. So what we would consider in the context of rehabilitation from chronic pain to be important, things like functioning and mental health and sleep, and is the child able to do the things that matter to them, that is almost never captured. And there's very little data being provided to characterize the level of communication or the level of motor function for the young people who are being studied in this research. So we also have very little to go off of in terms of who is this actually going to be applicable for. And so we know a little bit about assessment, but in some very specific contexts and not really how it relates to all of the other important areas of functioning for a child. And then in this more recent systematic review that we did, we were interested in shifting to look specifically at treatment and in the context of pediatric chronic pain. And so in this systematic review, we had two aims. We wanted to look at how well represented autistic young people were in what would be considered the gold standard literature. So this was any randomized control trial that was included in a Cochrane review of either pharmacological, psychological, or physical therapies for chronic pain. And what we found was that many studies explicitly excluded autistic young people. So it would say right in the exclusion criteria that young people with autism or developmental disability were not eligible to participate in the clinical trial. Over half of the studies had some level of implicit exclusion, which meant that there was some aspect of study participation or their inclusion-exclusion criteria that didn't specifically say that it was about autism, but would bias against the participation of autistic young people in that study. That would include things like requiring no co-occurring conditions or requiring verbal communication to participate in the trial. And then we were left with just over a quarter of papers where there was no exclusion criteria that should be systematically biasing against autistic young people, but also there was no representation of autistic young people in these papers. So that maybe they were included, but it wasn't reported. But what is more likely is that they were just not included in these papers, despite the fact that they would be eligible to participate. So what we can conclude from this is that we really don't have any gold standard literature that can speak to the treatment of pediatric chronic pain in autistic children and youth. Then we looked at the primary literature, so studies where they were specifically looking at the treatment of pediatric chronic pain in autistic young people, but this was open to any type of primary literature, and there's reasons why these studies weren't included in these Cochrane reviews. Most of them were case studies with 1, maybe 2 or 3 participants. They looked at a range of interventions, but several of what we would consider to be the key established treatments for pediatric chronic pain, so things like cognitive behavioral therapy, physical therapy, intensive interdisciplinary pain treatment, were not examined. Most often, these were actually surgical interventions for a painful condition. There were a variety of outcomes that were reported, which is actually an improvement over what we saw in those assessment studies. So many of these papers would talk about things like functioning and mental health and sleep. So that's promising, but because there was such a variety of outcomes reported and there was such high heterogeneity between these studies and so few participants in these studies, it wasn't possible for us to combine the data into a meta-analysis. And generally the evidence quality was what we would consider to be quite low, so not at the level of what would be included in something like a Cochrane review. So we know a very little bit about assessment, and what we can conclude from this is that we know almost nothing about appropriate treatment outside of these very, very specific case studies. So there's huge gaps that we need to address, and I'm going to invite Tim back up to talk a bit about how we've started addressing some of these gaps.
Yes, the gaps, they're huge. Turns out that we had this to confront. Does everybody know what this is? You think I'm a developmental pediatrician in pain, but actually infectious disease plays a big role in our lives. This is COVID, and COVID changed everything. So when we got started, we were very much locked into the idea that you bring kids back into the lab Tuesday at 2:00 in the afternoon, and that presumably tells you everything you need to know. Turns out that we were horribly wrong. So if you look at a typical lab-based data collection at, end of January, and then you pick up in March and June, September, and December. Okay, everybody's with me? Let's just say that's anxiety. This is a bar graph of anxiety. What do you think? Do you think that this looks like that person remains anxious across time? Yeah, pretty well. There's no difference from one moment to the next. But if you include data from invisible sources like everyday sources, you begin to see that there is enormous variation. There are hidden patterns, and that there's a rich story that is hidden away if you don't study data in a real world or repetitive longitudinal fashion. Okay, so we began to think a little bit about how do you take that concept and put it out into a program of research, and that's what underlay the development of the living lab at home concept. So typically Tuesday afternoon, you're doing in-person or clinic lab data collection. That tells you about what that person's feeling at that moment. But what about the week before? What about the week after? And so we began to develop a platform using a smartphone app, accelerometers and salivary biomarkers for stress. We're not going to talk about that today, but it was a concept of a multi-dimensional concept of looking at real-world data. Bringing kids back at 2:00 on Friday afternoon, of course, has the risk of recall bias. And so we wanted to go to point of time measurements to get away from that. Single point measurements, as you saw in the previous slide, really don't tell you about those hidden dimensions or patterns that underlie change over time. Single modalities, yeah, that's pretty good if you want to study anxiety on Tuesday afternoon. But if you want to look at the construct of how the child's living in the real world, interacting with others, and look at some positive valence affect measures like happiness and social interaction, you need to go to some multimodality approach. Also, the questionnaires that we're using were typically, if you use like a Spielberger, which is very good for studying anxiety, very good for anxiety. What about those other dimensions in the child's life? And so you'd want to look at data collection, where people live, and ask them questions that are meaningful in everyday life that make a difference to them. And so that sort of established the general concept of that underlay the living lab. And for the sake of time, we're not going to go into much more detail, but it was really an attempt to accelerate real world data collection in a way that made sense. Now, how do you do that? And for that, Kaitlyn's going to have to tell us about how we move from that concept to testing feasibility of the living lab.
Okay, so we wanted there to be a really strong component of patient and family engagement, sort of at the core of every stage of this, but right from the off, patient engagement was key. We thought we're going to invest a lot of time and effort into trying to make this in-home data collection work, then we should, at least start off having a sense of what families think is going to work for them before we try piloting anything. And it's been sort of this continuous iteration of trying things out, testing them, talking to families about what's working, what's not working, that has led to the methods that we're using today. So for the initial phases of family engagement, we were really fortunate to get funding from the Brain Behavior and Development theme at the Research Institute to do some of our preliminary work. And what we found from doing some initial engagement work, and this was with families who had lived experience of chronic pain, autism, cerebral palsy, and or severe neurologic impairment. And what families told us was that in order for in-home data collection to be effective for them, the protocols needed to be flexible. This was one of the primary reasons why they've never been able to participate in research before, is because there's been some aspect of the protocol that didn't fit for what their child needed. And this would include, some really seemingly small things, but like if we were asking a child to wear an activity monitor, if the strap wasn't comfortable or didn't fit for their particular sensory considerations, then they weren't going to wear it. We weren't going to get data. Families talked about wanting a reciprocal relationship with the research team, which meant that they wanted to be able to both inform the design of the study, but also to get something back from it. And the big thing that families were interested in was their data. Perhaps unsurprisingly, many of these families, particularly those who had kids who were more medically complex, would be collecting a lot of data already just in day-to-day life, trying to understand their child and their child's experiences. And they said, we're going to be giving you all of this intensive longitudinal data. We'd like to get a copy of it. That might be important for helping us to better communicate with our healthcare team about what's working and what's not. So they wanted a reciprocal relationship. And families talked about how, thinking about this flexibility and this reciprocal relationship was really key for the research to be accessible to them. And we did have many families who said, we've always wanted to participate in research, but we're never eligible, or there's always some aspect of participation that's just not going to work for us. And so families saw a lot of value in this form of research because the idea of also collecting this sort of micro longitudinal data felt like it was a better fit for them in terms of capturing the wide variability of experiences that are happening in their child's life. So we took a whole bunch of feedback that we received from families. There were those overarching themes from our qualitative analysis, but also some really specific kind of tangible suggestions from families. We incorporated that into the methods that we had been thinking about. So these smartphone delivered questionnaires, accelerometry for activity, physical activity data collection, and salivary cortisol measures. And we implemented that into some pilot feasibility and acceptability studies. The first of which was published last year, where we were looking at testing out these methods in autism, chronic pain, and cerebral palsy. And what we asked families to do was 14 days of data collection using these methods. We had some pre-registered benchmarks around what we would consider to be enough data or enough usable data to be able to then know if we should proceed with the methods as is, or if we would need to do some more iteration. And I think most importantly, we had exit interviews with families once they finished the data collection protocol so that they could give us feedback about what worked, what didn't, and help us to understand maybe where there were some gaps in their data. And this is a very brief summary of the tremendous amount of rich data that we collected. But what you see in that top heat map is for the accelerometer, the salivary cortisol, and EMA is the survey measurements. Across the days of study, how much data did we get back, basically, in which we called adherence to the protocol. So how much usable data did we get back? We only asked them to do the saliva for the first 8 days, which is why there's no data after day 8. But what you'll see is that we had pretty good adherence for the accelerometer and for the EMA, but that adherence tended to kind of drift off over the course of the 2 weeks. And we didn't have great adherence for the saliva. And what we found from conducting the qualitative interviews at the end of the study, which the themes of which are presented in those boxes at the bottom, was that for many families, the importance of the research question and how much value that had for the family was really critical to their engagement. So a lot of families said, I love the idea of this, but I actually don't get what you're doing. I love the idea of having more accessible data collection, but what is this study doing? And trying to explain to families like, well, actually, we're doing research about how we do research. They got the concept, but it wasn't as compelling as if we said, well, we're testing this novel treatment that might have benefit for your child. So many families said, if you had been using these methods to test out something that really mattered to us, we might have been a little bit better about keeping up our adherence to data collection over time. We also learned from families that data collection is not a passive or a neutral experience, and that if there's small issues, so say there's a question in the surveys that's triggering to a young person, or there's an aspect of collecting the saliva that is just kind of annoying, asking them to do that 3 times a day over the course of 14 days, that starts to become magnified over time, and their willingness to kind of continue with that aspect of data collection that's causing problems for them is obviously not going to be as high. So that's where kind of having personalized approaches and understanding the context in which families are going about their day-to-day lives is really important, because understanding which of these issues might have come up and finding ways to mitigate that or hopefully to preempt it is really important. And real life also happens during data collection. We had families during data collection who had an unexpected hospitalization, and being able to understand from families, what was going on that particular day, collecting that context data was really important for then interpreting what was going on in this daily experience data. And perhaps the most important thing that we learned, which maybe we could have guessed at, but it was helpful to sort of see this in action, is that talking about something is different than actually doing it. So even though we did all of this great patient engagement work before we started this pilot study, there were lots of things that families had asked for in the initial engagement work that actually, once they did the study, we did have some families who did both phases. Some families said, you know what, I thought that was going to work for me, and actually I didn't need it, I didn't want it, it didn't work the way that I thought it would. And so actually having that experiential opportunity to interact with these forms of data collection was really important to get some more nuanced feedback about what was working and what didn't. And I'll just say, I'm going to speak towards the end about some data that we're collecting now for another study that's used these same methods. And so our overall adherence in this study was around 60-ish% for the EMA. So that's the survey collection. And in our more recent studies, we're looking at adherence levels that are more around like 90 to 95%. So I really attribute that to the feedback that we've gotten from families and the efforts made to incorporate that, in addition to really making sure that the questions we're asking are ones that matter to families. So iteration is important. I'm going to talk very briefly about the sub-study that we did, which is the same general protocol as what we had done for the study I just showed on the last slide, but this was for families of young people with severe neurologic impairment. And we had an amazing summer student, Max, who worked on the data this past summer, looking at sort of the same idea, like how well is data collection working for these families, given the fact that these families are navigating a significantly higher level of medical complexity, many more demands. Many of the children involved in this study required tube feeding, mobility aids, didn't communicate verbally. So there was a much higher level of flexibility required in figuring out how to make the protocol work. And despite that, we had fairly good adherence to the protocol, and we heard some really important messages from families about really the importance of being able to attune to their lived experience in figuring out how to make data collection work for them. And in the context of this study, there were some additional pieces of feedback that families provided that were very specific to their young people, but was absolutely crucial for having a positive experience of data collection. One of the big things that we learned is that if you're studying a group of children who are on medications to control their secretions, that can make studying saliva collection more challenging. And there were a lot of workarounds that families were suggesting around how to make data collection work for them, because these are families who are used to navigating worlds that weren't built for their child. And being able to harness families' knowledge and experience and expertise around how to navigate systems that have previously been inaccessible was so much more valuable than if we had just been sitting in our own offices trying to think about how to make this work. So what we're doing now is using this pilot data that we've collected to apply for funding for different projects where we are actually asking a specific research question. So we're no longer just studying how to do research, but we're using this for some of our studies on pain and other developmental concerns. And within each of the studies that we're doing using these methods now, we are incorporating a component of continuing to study how the methods are working, continuing to get more feedback from families so we can keep iterating. And this is just to show the various projects that we have been involved in where we've used pilot data from the Living Lab at Home to put in a grant application to get funding to support a project that's answering a very specific question, but that is benefiting from that pilot work that we've done and that will contribute to collecting some of that data to do more iteration. And you'll see this spans questions from childhood, but all the way up to our work implementing the Living Lab at Home in the Poetic study, which looks at people who use substances during pregnancy. So really any kind of equity deserving population we think is a really good fit for this type of method and where we really benefit from that continued iteration. And I'm going to turn it back over to Tim to talk about sort of innovative technology and specifically how we've tried to address that ask from families to have that reciprocal relationship and access to their data.
So I think at this point, you're clearly getting the impression that we've got a research platform that is based on a co-designed model. It is an iterative design model that allows us to get feedback from the participants as we go along and make adjustments to the methods and protocols. It allows us to tap into real-world experience in populations that don't typically participate in research. And in that sense, there is an enormous amount that it offers. So if you're thinking about sort of what does this platform mean for you and your work, we need to think about that both at a research level, but we also need to think about when is this going to be ready for prime time in our clinical work, because we think that this has the capacity to change the way in which we gather data and potentially interact with our patients around complex conditions that do rely on self-appraisal, like pain, anxiety, aspects of mood, everyday behavior. So we had the great fortune of partnering with a group in computing science, designing for people group. And this is the work of one of the grad students we worked with, Unma Desai, who drew this wonderful picture of and coined the phrase, "My week in sight," which may very well be the name of our app if we ever go to the commercialization aspect of our work. And it clearly, this picture clearly represents the importance of putting the patient or participant at the center of data collection. And this is a graphical representation of what we have, and be happy to show you how the demo of the app and how it works with the dashboard and collecting real world data. But I'm going to give you an example in the next few slides, which was a study we did to capture everyday pain, anxiety, and related somatic symptoms. We started pilot testing this in a group of grad students. And of course, the way in which you start this is, of course, you go to a focus group and you show them this and you ask their opinion, and then they get them to use it, and then they give you feedback, and then you figure out how to make it better. And that iterative design trajectory really improved what we ultimately were able to use in the following study. We needed a way of capturing the variability in this dynamic thing called pain. It doesn't exist as a static phenomena. And so if you only measure it at 2 o'clock on Tuesday afternoon, you only learn about Tuesday at 2 o'clock in the afternoon. But here we wanted to look what was happening across a week. We also knew that pain occurred in the context of a diversity of lived experience that included both cultural, socioeconomic differences and neighborhood characteristics, which of course we weren't collecting here, but we knew that we could eventually link the data one would collect in a study. We also knew that we had to get perspectives from multiple informants and link that over time. Here's in this graph, lower right-hand side, you can see sort of what the graphic interface looks like that we would get off our 6 or 10 questions that we're asking in our smartphone app. This ultimately led to a pilot study paper, Making Data the Drug. We were really interested to know whether we could get data visualization of the responses over a 7 or 14-day period, and that would give us an idea of what the picture of the lived experience looked like, on the assumption that if the participant and ultimately the patient could see their data, they would be able to interact with their data, and they could engage with their clinician in a way that would allow them to have a conversation about what that lived experience looked like, what they were feeling, how they were, who they were interacting with, and whether they took medication to mitigate some symptom that they had. We were particularly interested in symptoms. We were not interested in diagnostic or categorical constructs. And so the kind of questions that we were asking were things like worries, happiness, who you were interacting with. Did you worry about something in the morning? Did it happen in the afternoon? The cool thing about this micro-longitudinal data collection is that it gives you a temporal character of whatever construct you're looking at. So for example, the work that Veronica Dudorov, who's a research associate in our lab, has done, has characterized worries by physical activity. So how many, not steps per day, but what the distance traveled, was that dependent on whether you were worried about something or had a symptom in the morning and were you treated in the afternoon. So you could look at temporal character, which you typically could not do if you were just looking at a paper and pencil type of response. These are heat maps of what the data could potentially look like, tracking, motivating, and combining different types of data. So physical activity data combined with self-report offers a very powerful tool for looking at what that person's experiencing and how they acted. We also were interested in, did they go to sleep? Did they go to school? Did they interact with friends? And again, looking at a heat map like this can tell you about not only did something happen, but you could also code it by intensity. So you can see that different colors appear across the week. Okay, so what's next? Answer, Kaitlynn will tell us.
I am literally what's next in the slides. So, I mean, one of the first steps that's happening next is that we had developed that data visualization platform initially just with our general chronic pain population. And we have a student now who's working on pilot testing how that data visualization platform is working specifically for autistic children and youth. Are they understanding the data in the same way? Do they want to see something different? Are they drawing the same impressions from their data? Are there things that we need to adjust to make it more accessible? So that's one thing that's coming up next. And I mentioned earlier that we have been using some of those living lab at home methods to actually do some studies around understanding pain. And this is data from a couple of months ago. We're getting close to our target sample size of 100 now. But I'm not making Veronica redo all the heat maps in the meantime. But this is a study where we're looking at autistic children, youth, and young adults. They don't need to have any pain condition or diagnosis to participate in this study, but we're interested in just understanding, like, what's the everyday pain experiences of young people? How common is something like chronic pain? Where in the body is pain located? How intense is it? What are they doing about it? How does it relate to other factors like sleep, mental health, masking or social camouflaging, sensory sensitivities? And this is just to give you one tiny little snapshot of this huge wealth of data that we've collected from these young people, where we've had really good compliance with the data collection protocol, just to show how pain is highly prevalent in this population. So each column here is one participant, and the intensity of the shading is how much pain was experienced over the course of the 14 days of data collection in these different body parts. And so what you see is that pain is very present, and it's also highly variable in terms of where it's showing up, how often it's showing up. And what we're interested in being able to do when we hopefully wrap up data collection soon is to look at some of those associations between pain experiences and other things that are happening in the course of the week, to see also what is pain predicting and what is pain predicted by, because we have that temporal data that we can look at. So this is everyday pains in autistic youth. And we also have two studies that we're in the process of wrapping up, looking at taking a more qualitative perspective at understanding experiences of young people who are living with chronic pain, who also hold an autistic identity, and for parents of autistic children who have chronic pain. And this is a picture of Michelle, who's a honor student who's working on this data. But just some preliminary findings from the 21 youth that we've involved in this study so far is showing that there are some real barriers to having pain recognized in autistic young people, and barriers to navigating healthcare. So many young people said something along the lines of what's represented in this quote here. As soon as I tell them I'm autistic, you can see their face change, and they'll doubt my ability to advocate. So many young people, even young adults who were living independently, would feel like they'd need to bring a friend or a family member with them to advocate on their behalf, because as soon as they disclosed their autistic identity, they felt that they were no longer being taken seriously. Many young people also talked about the balancing act of meeting their sensory needs, but also doing everything they needed to do to manage their chronic pain. Many young people talked about having to avoid sensory overstimulation in certain areas, but also seeking out certain forms of sensory stimulation as a way of modulating their pain experience, which sometimes came in the form of self-injurious behaviors, which many young people would say, my clinician really says this is a bad thing, I shouldn't be harming myself, but I do that to try and direct the sensation away from this chronic pain I'm experiencing in a different part of my body. So it's a very common finding, and this relationship between both sensory sensitivity and sensation seeking and pain seems to also be panning out in our quantitative data from the study I just mentioned. And many young people also talked about this challenge with interoception, having a hard time distinguishing something like hunger from physical pain and feeling like the wires get crossed. And then many young people also talked about the importance of things like gender, socioeconomic status, racialized identity, body size as being important in understanding how they navigated accessing the healthcare system for their pain. And many young people had experiences of feeling that it was not just their autistic identity, but the combination of their autistic identity with another social position that led to them not being taken seriously or not being offered appropriate interventions or follow-up. And then when we spoke with parents, we were hearing some pretty similar narratives. One thing that was really important in many of these stories was that many parents were also navigating their own experiences of neurodiversity or of chronic pain, and that made it especially challenging to harness the executive function, the emotional energy required to advocate for their child and to navigate the complexities of the healthcare system. Many families talked about being dismissed by being told, your child's pain is normal, this is just what's expected, but simultaneously also being told you're too complex, we can't offer anything for you. And families spoke about how inaccessible treatments were at both system level, where they're experiencing gatekeeping and siloing, that pain providers didn't know enough about autism, the autism providers didn't know enough about pain, but also at an individual level, that sometimes they would be given treatment options that required, having their child be motivated to engage in, say, physical activity, or being asked to do something that was associated with a really high level of sensory aversion, and feeling like they didn't have, they weren't provided alternatives of how to navigate that. And I love this quote from one of the parents in our study that I think just really sums up the incredible burden that these families are facing in navigating the healthcare system, where they said, most people take their kids to activities after school, we take them to treatment. And most of the time finding that treatment is not effective. So we've told you a bit about where all of this work has come from, our work in trying to identify some of the gaps in supporting young people with complex developmental needs and chronic pain, how establishing the Living Lab at Home has offered us some opportunities for doing research in a different way that's really been in partnership with patients and families and informed by their priorities, and some of the lessons that we've learned along the way, and how we are hoping to continue to do work in this area, but also expand the work that we're doing with the Living Lab to partner with other research groups to continue to use these methods and use what we've learned so far. And we have a couple of specific projects that we're working on around looking at, what does clinical data look like and how are things documented for autistic young people who live with chronic pain. We're looking at linkages with big data to be able to do some larger scale epidemiological studies, hopefully linked with Living Lab at Home data to be able to combine sort of big data both on the micro-longitudinal level and the administrative health data level. And we were also really fortunate to get some funding from the Mayday Fund to hold a priority setting meeting in the new year, engaging researchers, clinicians, and folks with lived experience of pain and autism together to really set a research agenda for where the field needs to go next in tackling this problem, the overlap of pain and autism. And just a big thank you to all of the funding that we've received to do this work, the collaborators, and of course the patients and families who are really at the center and the heart of everything that we do. And thank you all for your attention.